So welcome to our first event called Lives Saved, Integrating Harm Reduction into Tobacco Control, where we'll discuss the latest report which we are launching today, in which a group of esteemed authors have estimated the numbers of lives that could be saved in 4 countries if tobacco control policies were accelerated. These countries are South Africa, Pakistan, Kazakhstan, and Bangladesh. The lead author of the study is Dr. Derek Yach of the US and South Africa, and he will introduce the report very shortly. Firstly, I will briefly walk you through the agenda for today and the speaker biographies. So, Dr. Derek Yach will firstly give his keynote speech, where he'll introduce the report. And then we have Dr. Hosilet Lapi of South Africa, and he'll discuss the importance of the study in selected lower and middle income countries, of the 4 countries I've mentioned. And then we have Dr. Carl Fagerstrom of Sweden, who will discuss Sweden as a role model for saving lives in tobacco control. And then we'll have Martin Cullip of the UK, who will talk about empowering consumers through his methodology and the report. And then we have Dr. Abbas Raza, who will join us online. He'll be from Pakistan, and he'll discuss the importance of the study in Pakistan. And then we have Dr. G. Kentra, who will join us online from Kazakhstan, and he'll discuss the importance of the study in Kazakhstan. And then we'll be joined by the co-authors of the report for an online panel session, where we'll ask them for their comments about the report. And then Dr. Dilon Human and Dr. Derek Yach will close today's session by 12:30 London time. Okay, so the first person we have here is Dr. Derek Yach. Just please bear in mind that the full biographies will be available in the report at the end of the report. So I'll keep it very short for the purpose of today's session. So Dr. Derek Yach is a global health consultant with more than 30 years of experience in public health. We have Dr. Hosilet Lapi of South Africa, who is a physician, he's an ophthalmologist, and he's currently a founding member of the Africa Harm Reduction Alliance. We have Dr. Abbas Raza of Pakistan, and he is currently a consultant endocrinologist at a leading research center and hospital in Pakistan. We have Dr. Dilon Human of South Africa and France, who's a specialist family physician, a healthcare consultant, and specializes in global health strategy, harm reduction, and health communication. And we have Dr. G. Kentra of Kazakhstan, who is a cardiologist and deputy chairman of the Harm Reduction Association of Kazakhstan. We have Professor Carl Fagerstrom of Sweden, who is a clinical psychologist and currently a deputy editor of the Nicotine and Tobacco Research magazine. We have Martin Cullip of the UK, who's the International Fellow at the Taxpayers Protection Alliance Consumer Centre, and he has taken part in parliamentary evidence sessions regarding tobacco and nicotine policy. And then we have our panel members. So we have, these are the other co-authors of the report. We have Solomon, who's a psychiatrist from South Africa. We have Mihaela, who's a dentist from Romania. We have Diego, who's a surgeon from Argentina. Anoop, who's an endocrinologist from India. Anders, who's a physician from Sweden. Ricardo, who's a physician from Italy. Heino is a social scientist from Germany, and Hiroya, who's a surgeon from Japan. So now we will move straight to Dr. Derek Yach and his keynote speech. So Derek, are you ready?
Yes, thanks, and thank you, Jessica. I'd love to have been with you, but good to see so many friends and colleagues on the line. Let me jump straight to it. I think we know the data on smoking, 8.5 million deaths from tobacco-related products, and against a backdrop of 1.27 billion users worldwide. I always start with those figures to then ask the question, are we making progress or not? And I think with the level of figures, we must admit that the Framework Convention provisions and Empower, funded by Bloomberg Philanthropies, is failing the world. We are well off target for most of the SDGs, particularly those related to non-communicable diseases. And without getting tobacco back on track, we don't have a hope of achieving them 20 years out. So, given that, a group of us, and I'm thrilled to have many of you with us, felt that the time had come to look at one of the big missing elements, and that is We know that over the last 20 years, we have seen spectacular advances in diagnostics, new treatments, new approaches that are having a profound impact on cancer survival and outcomes, on HIV/AIDS, and of course, in the last few years, we've seen the benefits of technology for COVID. That kind of approach of recognizing that the future of interventions for health is not static, but needs to adapt to the technology innovations of the time, has never been applied in the area of tobacco control. And in fact, a read of the Framework Convention shows that we didn't even consider issues of patents, intellectual property, breakthrough innovation. With that in mind, we felt that it was time to look at what would happen to the long-term health of tobacco-related death and disease if we were to apply three be washed out once people quit. So the countries we focused on include Bangladesh, South Africa, Kazakhstan, and Pakistan. We chose those countries because they each have different characteristics, but between them represent low-middle income countries. Most of the excellent modeling work has been done in developed countries, and we drew upon those science and insights. And unfortunately, most of the harm reduction products are being marketed, sold, and distributed also in high-income countries. We felt it was time to put a spotlight on the majority of the world where we don't have access. So Bangladesh and Pakistan represent countries in Southeast Asia and South Asia where smokeless products, toxic smokeless products, play a very strong role in death and disease, particularly oral cancer, alongside combustible products. In Kazakhstan, we have very high levels of combustible use, particularly among men. And we know that what is happening in Kazakhstan is not too different from many of the other ex-Soviet Union countries, as well as across Eastern Europe. So looking at Kazakhstan is giving us a world view into a very important part of the world where smoking rates are extremely high. And of course, South Africa, being on the African continent, gives us a reflection of what could or should be happening in South Africa. If we actually then say, well, how did we do this study? Well, the experts on this call and others were polled to ask, what are their best estimates in terms of the benefits of tobacco harm reduction and some of the technologies over the next few years? We informed those results by looking at the published literature, including the literature from the modelers. And in the report, you'll see the details of which estimates we used and didn't use. Importantly, we wanted to acknowledge that the current path of WHO is having an impact and will over the next few decades. We wanted to know how much faster, how many more extra lives could be saved by adding in these technological innovations. So let me jump to the results. And if we could have the slide on Bangladesh, for example. Very importantly, when you look at the curve, you'll see that the decline in deaths starts a bit slowly and then picks up pace. And that's because of the lag effect I've mentioned. So in Bangladesh, we estimate that about 920,000 deaths, additional deaths, will be prevented if we were to apply the combination of tobacco harm reduction, better cessation, and better diagnostics and treatment for lung cancer. That's a huge number, almost 1 million people. And importantly, again, I mentioned that this is in the context of a country with very high levels of toxic smokeless tobacco use. The good news is we're starting to see the uptake in nicotine pouches, and we hope that we'll start seeing many of the other products launched onto the Pakistan market. These are big numbers. In red, you see the WHO status quo figure, which is falling further and further behind what we could be achieving. Let me turn to the second country, which is South Africa. And very importantly, you can see that 320,000 lives would be saved. If we just change the slide to South Africa, 320,000 lives would be saved. Now, to put that into context, remember that during the period when President Mbeki clamped down on the use of antiretrovirals, the estimates of the economists were that about 330,000 people died needlessly because of the lack of access of antiretrovirals. Well, this is almost the same figure, but do we have the same level of outrage and outcry about demanding that this needs to be fixed in the way we saw with antiretrovirals? Sadly, the answer is no, and I hope Josi will pick that up. The third country is Kazakhstan. And again, if we look at the figures, about 165,000 lives to be saved in Kazakhstan. And remember that this is a country where the levels of wealth are growing pretty fast. Smoking rates among men are at 50%. Smoking rates among male doctors are not much different, all suggesting that we need a major push to try and get progress in Kazakhstan. And what happens in Kazakhstan will happen in Turkmenistan, will probably happen in Georgia, will probably happen across many of the Eastern European countries. And then finally, let's look at Pakistan. Pakistan. So across Pakistan, we'll see that 1.2 million lives will be saved if we were to apply the same logic. And again, given the enormous size of Pakistan and the fact that what is happening in Pakistan potentially could have a benefit also in India, the consequences therefore apply to well over 1 billion people in South Asia. Our hope is that the policymakers in Pakistan will use this data to do what's happened in many other countries when you present them with what we could be doing to save lives, and that is to start saving lives. Very importantly, while we focus here on the deaths, we don't highlight the enormous disability, suffering, pain, and low productivity, economic hardship that comes through the use of tobacco products. Factor those in, and you have an even more powerful argument both on the health and the economic side. So let me then turn to saying, so what does this mean? What could we do? What actions do we suggest as a group? And we really call for 5 sets of actors to do something. First, WHO. The meeting in Panama City next month is replete with calls for bans, restrictions, prohibitions, controls over tobacco harm reduction. We believe that the member states need to come armed with arguments, including this data, to say that if we embrace tobacco harm reduction fully and strongly, we will be able to save many millions of lives. I just showed you from our studies how we could save 3.5 million lives across 4 countries. The figure would be in the hundreds of millions if we applied it across the world. And remember that we're not talking about products that nobody knows anything about. The report outlines incredible progress in seeing smoking rates come down while the use of either snus or nicotine pouches or heated tobacco products or e-cigarettes are going up. And this is across countries from USA, UK, Japan, of course, Sweden leading the way, and even Pakistan. So we believe that it's time WHO activated the components of harm reduction already embedded in the Framework Convention. They don't need to change the wording. Second, governments need to act far more decisively. And the very specific call is they need to regulate these products proportionate to the real risk that they have to the health of the population. In practical terms, that means taxes on combustibles and toxic products should be substantially higher than those on the cleaner nicotine products. Why? Well, the greater the gradient in price, the more likely it is for consumers to switch with ease and to encourage them to switch with ease. Secondly, on messaging, marketing, and advertising, we need a differentiated approach. You can't slap the same warning onto a nicotine pouch that you've got on a combustible cigarette, when in fact you want them to know that the use of this will accelerate your probability of quitting cigarettes and is safe within a very wide boundary of margin of error. So we need to change the marketing and advertising also to be proportionate to the real risk. Thirdly, we highlight the centrality of physicians and other health professionals, dentists, nurses, in playing a leadership role. At the moment, we know that there are massive surveys showing that 70% of doctors or more believe that nicotine causes cancer, which of course it does not. Unless we can reverse this, we're not going to get them to engage in their clinical setting to provide the advice. Their patients coming to them either because they are smokers or because they've got even early stage disease. We need a greater activated group of physicians to do what they did at the beginning of the tobacco epidemic, sound the alarm, demand policy changes that save lives. And we need the equivalence of the Royal College of Physicians report of 1962 or the Surgeon General's report of 1964 for Kazakhstan, for South Africa, for Pakistan, and for Bangladesh, led by physicians. Fourthly, we know from the experience from HIV/AIDS that the phrase "nothing for us without us" effectively meant the activists who were most effective became the activists to drive policy change. In the area of tobacco harm reduction, we've seen this only very rarely. A good example was 10 years ago when the e-cigarette user groups successfully lobbied at the European Union for a change in policy. Well, that was a decade ago. We need to see how they could be galvanized to be a stronger force to say it's our lives, it's our health. We demand that we actually have tobacco harm reduction available and not do what appears to be happening in many countries, reversing access to life-saving products. And then finally, the tobacco industry. Let us never forget that the data shows us that the majority of the profits and the sales and marketing are directed to high-income countries. We need to see a much swifter focus on the countries mentioned in this report and other low-middle income countries. That would actually really save the 80% of deaths due to tobacco. And finally, with regard to the industry, we know that some are starting to look at medically licensing their products, particularly e-cigarettes and nicotine pouches. I believe that while this shouldn't be the predominant way we're going to get tobacco harm reduction products out, by having things go through the medical licensing rigor of, say, the FDA or the MHRA in the UK, it gives a halo for the doctors, the physicians, to be able to feel confident that if they give these to their patients, they are doing so within a medically strongly assessed, science-based approach. And that could have a halo effect for the entire set of tobacco harm reduction products. So we hope this report will lead to discussion, debate, but most importantly, to action within these countries and within all the countries taking part in the Panama City meetings next month. Thank you.
Thank you very much, Derek, for your speech, especially as you're dialing in for very, very early in the morning where you live. So I presume the sun's not even up yet where you are. But before we move on, any questions for Derek online or in the room from any of the speakers? No? Okay. So we'll move on then to Dr. Hossi Letlapi, who will join us online from South Africa. And he'll speak about the importance of this study in the selected lower and middle income countries and the 4 countries in question studied in the report. So, hello, Hossi. Would you like to start? Hello, we can see you. Yeah, loud and clear. Yes. Yeah, feel free to start when you're ready.
Not going to follow the script because I think following on what Derek has said, the main message from me is that smokers' lives matter. So you have this lens of morality that we apply in society. The challenges that we saw for people living with HIV in South Africa was because of looking at them through the moral lens. So they were not seen. They were thrown out of their own homes. They were thrown out of their places of worship because of the association of sex, sin. We have the same attitude towards liquor, towards tobacco, things that bring joy to people. So we celebrate misery, and we are anti things that give pleasure. Now, some of these things that give pleasure can also cause harm, as we know from HIV. So what do we do with them? If we can't avoid them, how can we reduce the harm associated with them? Just like we do for motor vehicles. But because it is smokers, and there's this lens where society has not accepted them, we've basically ostracized them from society. They are basically not seen. Even though we have challenges with alcohol, in my community, when people throw a party, they'll give you alcohol, but nobody gives you cigarettes when you go to their party, because smokers are not seen, and education doesn't help. So smokers cannot mobilize for themselves. Even with people living with HIV, as doctors, we left them to their own. Because they were dying daily. It was graphic, it was visible, it was intensive, it weighed on the system. Some of us had to wake up to the realities that people living with HIV faced in our country. And we pledged solidarity with them. As the chair of the association, I got the association to become a member of the Treatment Action Campaign. Now, for smokers, there's no such relief, because active smokers are seen as bringing it to themselves. And what aggravates it is the history of the tobacco industry and the hatred of the tobacco industry from public health and the WHO. And smokers are the victims of that hatred. Hatred is toxic. Hatred will always make human beings do irrational things. Now, the challenge for Africa, the challenge for South Africa, the challenge for LMICs is the conduct of the WHO in this matter. They cannot live up to the true terms of the FCTC. There's Article 1D that talks about harm reduction. When it was written, there weren't any products except for snus, which the WHO banned. And we know what has happened in Sweden, where snus was not banned. And there's a challenge about a problem where people don't take accountability. If the WHO was run by people with a conscience who think people who smoke matter, they would be making amends for having banned snus with disastrous consequences. The article that came up in 2020 that says if snus had been adopted in Europe, 350,000 lives could have been saved. But nobody does anything about it. So our problem in Africa emanates from the attitudes of the WHO, where the FCTC, which is a framework convention for tobacco control, written for combustibles, is now being used to force consumers to combustibles by being untruthful about the relative harm of the non-combustible alternatives. That is the key, that is the challenge, and that's what we need to deal with. We have a challenge in many African countries where a significant portion of our health expenditure comes from donations facilitated by the WHO. So there is no ability not to listen to what the WHO says. And the challenge we have now is to speak truth to power that is being abused by the World Health Organization. We need frameworks that accept the fact that these products are less harmful than combustible products. I ask myself, when we come up with legislation that does not differentiate between the two products, that when you do not combust, you reduce harm, why would the medical profession have supported nicotine replacement therapy? If, as is being suggested, nicotine is now being labeled as highly addictive and highly toxic in the proposed bill in South Africa. And I'm saying, does it mean we as a medical profession have lied to society providing nicotine replacement therapy. It is time we tell the world and we tell the WHO that people who smoke matter. Their lives matter. It has an impact on all of our societies. My father smoked. I've been a passive smoker all my life. One of my kids uses nicotine. Many of my nieces and nephews use nicotine. And I need an enabling environment to educate them properly about the dangers of combustible cigarettes. That if they can't quit, they can't be left to die. We cannot sacrifice 30 to 40,000 lives in South Africa on the altar of trying to protect the youth. Youth uptake should be discouraged. We should work together about what we do about youth uptake, but it should not include prohibition or banning of products that will reduce harm to adults. Prohibition is abdication, because when you ban and prohibit, you can't educate, you can't protect, you can't ensure that people have access to safe products. And that should not be allowed. We need to ensure that there is access to alternatives. The alternatives are affordable, and society is educated about the benefits of avoiding combustion. Taxation becomes important, pricing becomes important, but the way we save lives is by educating, it's by empowering, it's not by distorting facts. When you have 70% of doctors saying that nicotine causes cancer, you know that we've got a huge mountain to climb, in the words of Nelson Mandela. And we need to ensure that we change the WHO to be a protector of all humans, including the 1.1 to 1.3 billion people who smoke. They should not be sacrificed at the altar of hatred. Trust is not compulsory, but we all need to respect each other. All of us have to be at the table. So we need to ensure that this secret club at the COP10 is disbanded. NGOs should be at the table, not the ones selected by the WHO, the ones that choose to work in the space. People who smoke, people who vape, they should be at the table. The industry should be at the table. The WHO should promote science and not take sides. And we need to ensure that the truth is spoken. I'm tired of dilly-dallying. For those of us in low middle income countries, WHO, which is supposed to protect us, is the one that is causing most harm. The WHO promoted COVID-19 vaccines on an experimental basis when we didn't know about the safety profile of those drugs. We know the safety profile of snus. We know the outcomes of introducing non-combustibles to your society. The gateway theory has been debunked. It is time we stood up for truthful information. It is time people are given the truth, credible information, and we ensure that markets ensure that there are alternatives that are affordable. In our countries, it's usually the poor that are dependent on nicotine, and they need to access less harmful alternatives at an affordable price. The governments need to come to the party. The WHO needs to come around. We need to regulate based on science and based on policy. And like I said, people who smoke, their lives matter, and it's time that they are seen in society.
Thank you very much, Hossi. That was a very powerful and impactful talk, and your messages came through very loud and very clear, so thank you very much. Are there any comments for Hossi at all, briefly, in the room or online? There are. Yeah.
There's one question from Kurt. He's asking why can't consumers participate in the solution, and maybe a further point to that is how can consumers participate in the solution?
Did you hear that, Hossi?
Yes, I heard it.
Yeah.
That's why I'm asking that everybody that has an interest in this should be allowed at the table. And on the principle of nothing for us without us, the consumers are the most important.
Thank you, Hossi. Okay, we'll move on to Dr. Carl Fagerstrom from Sweden, who will discuss Sweden as being a role model in tobacco control.
Thank you very much. Okay. So good morning or good evening, depending on where you are on the globe. What I would like to do is to show you that harm reduction is not just a theoretical construct, but it's really something that can yield important, significant effects, and that is reductions in death and disease. And on this very first slide, we can see what happened in my country. The blue is snus and nicotine pouches, and reddish is cigarettes. And as snus started to be more used, cigarettes started to be less used, and there is a communicating jar. And today there is more tobacco going to snus than to smoking cigarettes. And this has resulted in a very low smoking rate. In the very left of the picture here, you see Sweden, which is around 5% of daily smokers compared with the rest of the European countries. And we see that Sweden is an outlier. If we were to look at tobacco use in Sweden, we would be at the same average as the European Union. That means cigarette smoking and snus use together. But this uptake of snus has resulted in something. And this is the most important slide that I have. And on the top, upper half of the slide, we see figures from World Health Organization. And we are looking at attributable deaths to tobacco per 100,000. And we have Sweden, if we go down to all causes, 222, while for the European Union, the median is 550. So that's quite a big difference, very big difference. And for all causes, the country that has next lowest figure is on 378. And Sweden 222. And we see the lower death rates in Sweden on lung cancer, other cancers, but also cardiovascular disease. And if we were to use another data set from the global burden of disease, we would see very much the same. So harm reduction is paying off. The global burden of disease, they have arrived to an interesting statement that I would like to read to you. There is sufficient evidence that chewing tobacco and other products of similar toxicity cause excess risk of oral and esophageal cancer, while at this time existing evidence does not support attributing burden to snus or similar smokeless tobacco products. And globally, smoking tobacco causes far more burden than smokeless tobacco. Because of that, Swedish snus was the first and so far the only product to be recognized as a less harmful tobacco product by the Federal Food and Drug Administration in the United States. And the former commissioner of FDA, he said nicotine, while highly addictive, is delivered through products on a continuum of risk, as we have heard the two speakers before me. And that in order to successfully address cigarette addiction, we must make it possible for current adult smokers who still seek nicotine to get it from alternative and less harmful sources. And it so turns out that nicotine and tobacco is an ideal area for harm reduction. It's used largely because of nicotine, and pure nicotine, like in nicotine replacement products and even unburned tobacco, is not a big part of the problem. And the problem, that is the health consequences. It's not the prevalence. The prevalence, to have a low prevalence is a mean, but if prevalence of a use of something is not dangerous or very dangerous, I wouldn't care that much. What I care for, that is the harm, the death and disease. And it's funny, or no, it's not funny, it's sad actually. There is a lot of emotionality in tobacco control. For example, from the same data, European Union has banned snus, while FDA has given snus a marketing advantage as being a less harmful tobacco product. And if anything should be prohibited or banned or phased out, it should be cigarette smoking and not the alternative products. We have tried to figure out a little bit in Sweden what would have happened if we had no snus use. And under the assumptions here, we have all of snus users today would have smoked. Then we would have had 4,000 more deaths. However, it's unlikely that all the snus users would have smoked. So if we take a more conservative assumption that half of today's snus users would have smoked, then we would have 2,000 more deaths, or conversely, we are saving 2,000 deaths per year because of snus use. And if we compare 2,000 deaths to the death we have in traffic accidents, that is 227 per year. So you see the difference, how much public health benefits you could harvest from doing the right thing with tobacco control. And finally, I'm very glad to announce that the Swedish government has proposed in a proposition to the parliament that the tax on snus should be reduced by 20% and increased on cigarettes by 10%. And this is on health grounds. So my conclusion is that in Sweden, it has been the product snus that has displaced smoking. And snus has significantly reduced death and disease in Sweden. Thank you very much.
Thank you very much. Thank you very much, Carl, for highlighting the importance of Sweden and how it's incorporated harm reduction in tobacco control. So that was great. Are there any comments for Carl whilst he's here? Online or in the room? No? Okay, thank you again. So now we move on to Martin Cullip. Would you like to stand or sit? Okay, yeah, sure.
Thank you. I'm here as a consumer advocate. I smoked for 33 years and I quit smoking using vapes. I also use nicotine pouches. And on behalf of consumers, I'd like to say this report is quite important. It's a review of the evidence. It draws on academic research to gather that evidence. And the figures, as we heard gone through earlier, are quite stark. Kazakhstan, 165,000, 320,000, 920,000, 1.2 million lives. These are big figures that could be saved if we had better regulation of less harmful nicotine products. And these figures should excite the WHO and NGOs that are dedicated to eradicating the harms of combustible tobacco use. But for some reason, they're determined to ignore them. We know again, as the report mentions, Japan, Sweden, UK, they've all had dramatic declines in smoking due to these products. So we know harm reduction works. It's in the evidence, we can see it. As again mentioned earlier, 80% of people who smoke are in lower middle income countries, and that's the WHO's own statistic. So what's happening? Let's take two examples. At the moment, in India, there are 100 million smokers, and 200 million of the citizens there use other tobacco products, lethal tobacco products. Yet vapes are banned. Nicotine pouches are being opposed, despite being far safer than the lethal oral products used by millions of people in India. Worse, India has banned research into safer products. It's made possession of vaping products a crime, and recently told an organisation which held a discussion about vaping that they had broken the law. In South Africa, new proposed legislation not only puts huge obstructions in the way of harm reduction, but also makes an offence for a consumer advocate to make a positive statement about switching from smoking to a smoke-free product, punishable by a maximum penalty of 10 years imprisonment. The WHO is eagerly cheering on this madness. It seems to have lost its moral parameters when it comes to harm reduction. We know that policies in countries where harm reduction is regulated sensibly see faster declines in smoking prevalence than where it's not. The evidence is clear that the WHO and the tobacco control industry refuses to acknowledge it. As Kosi mentioned, the FCTC treaty includes harm reduction in its preamble. The WHO and many public organisations, though, are set on a policy of harm maximisation, not harm reduction. The WHO's preferred outcome in Panama at COP10 is that countries ban all alternative nicotine products outright, leaving combustible tobacco as the only legal nicotine product. This is patently absurd. And the only possible outcome of such regulations would be to protect the sale of cigarettes. Whether the WHO likes to think of it like that or not, that's basically what's happening. International treaties are supposed to have aims. They have three aims. They're meant to make sure that countries sign up to them. They're meant to make sure that the countries that are signatories to the treaties are implementing the policies that come out of the decisions for the treaty. But they're also supposed to measure outcomes and see if those policies are actually working. The WHO's FCTC treaty does the first two, but it's not too worried about the outcomes. Its empower policies are just box ticking. Taxation, you can apply taxation, you can apply smoke-free regulations, you can do all that. But if it's not actually doing anything good for outcomes, then it's not having any decent effect. In 2003, when the FCTC treaty was written, there were 1.1 billion people smoking. Now, 20 years later, as we have heard, there are 1.27 billion. Now, some of that can be explained by rises in population figures, but it's clear that FCTC's current approach is not making a big dent in smoking-related diseases and smoking prevalence. You can't restrict and ban your way out of a market for nicotine, which has existed for 12,000 years and for which there's still a huge demand. It's naive and foolhardy for the WHO to think it can. As a consumer, I know all about the WHO's own Ottawa Charter, which declares that the public has a right to opportunities and resources to enable all people to achieve their fullest health potential. Yet the WHO is working to remove access to safer products for those of us who have quit smoking using them and for people who currently smoke. The Charter further states that people cannot achieve their fullest health potential unless they're able to take control of those things which determine their health. Yet we have no control over what the WHO FCTC process decides because the public is barred from participating or even observing. It's well past time the WHO FCTC took notice and listened to the public it's supposed to be serving. Of all stakeholders, consumers are the most affected. We advocate because we know what worked for us and want to share that experience with others. Consumers are the most powerful voice in this debate. We should be included in the discussions. We're passionate, we are committed, and we know we are on the side of the angels. The evidence in favour of harm reduction is increasing with every passing month. This report adds yet more to the armoury that consumers can point to in making our case, and we will continue to do so, despite WHO's policies. Thank you very much.
Thank you very much, Martin, for your very informative talk and for being such a powerful and important voice for the consumers. It's very much appreciated. So now we can move on to Dr. Abbas Raza from Pakistan, who should be online and ready. Hi, Abbas.
Yes.
You're welcome.
Hello.
You're welcome to start when you're ready.
Okay, all set. Again, when you're meeting with a group who is so committed in mission, it's always working with a group. And I find myself in a group of people who are not only committed in the betterment of the nation as well as in general, but I think they are also focusing on something which is very, very important to us all. I can vouch for the importance of it, having served in Pakistan Endocrine Society and then in South Asian Federations of Endocrine Society, which is a regional organization as the president, and currently working as president of International Society of Endocrinology. I do realize the fact that it is not a local, regional, or in a limited way. It's a global problem how we deal with it. Unfortunately, we try to cut and paste most of the rules and regulations from one single place to globally, which actually exposes a lot of limitation in those rules and regulations. And again, I know example of India was given how if you implement from a certain part of the world in a bigger region like India, what limitation those rules can implement, like banning the vaping devices, and again, the research in it might have made sense in certain part of the world, but in our part of the world, we need to realize that this problem remains a major problem. And I like and I love how Dr. Letlepe has mentioned earlier about the stigmatizing the whole smoking process in general. Why do I say this? Is the problem is we have done surveys in Pakistan and surveys regionally in which we try to find out how many people are chewing tobaccos or smoking tobacco to help us give the ways how to limit the use, how to let them know the complication of it. And we found out because of the stigmata associated with smoking, which has generally been publicized very nicely, but that has limited people coming out and telling us in the surveys that they are smoking. Probably unfair, because if they come out and they tell us that they are smoking, the society in general look at it as if they're outliers. And I think that goes against the gist of our preventative efforts that we are trying to do. And I think realizing that that there are people who opt to take use tobacco, what we need to tell them now is that which is the safer way to do it. And I think this paper just comes at the right time, in which we are not only going to tell them, or we are proposing that there's certain measures which can help people use the tobacco in a less harmful way, or much safer way, apart from like chewing a tobacco or smoking or smoking a tobacco, burning a tobacco in form of cigarettes. The other important point coming from our region is that we live in an area where chronic diseases, the Southeast Asia, India, Pakistan, Nepal, Bangladesh, we live in an area where is an epidemic of chronic diseases, which not only include diseases which are very prevalent in this part of it, which is diabetes, but also diseases like infectious diseases like TB. Why do I bring this up? We know that if you are using tobacco, like chewing tobacco in certain conditions, you are exposed to more of an harmful effect as compared to using the safer methods of using tobacco. And that's just a stepwise approach. So we living in a chronic areas where the chronic disease is very prevalent, we need to realize that we need to separate the ways how we approach this problem. Number two, we need to provide alternatives to the use of tobacco use, so that people start using the lesser forms less and harmful forms of tobacco. We are working on diabetes and tobacco use and the complication. We do find out that there's not enough data, there's not enough information on vaping and diabetes and the harmful effect of it. Till that point, there's definitely an harmful effect of smoking, burning tobacco, a part of it. But again, if you look at the safer ways of it, you can transition these individuals into lesser harmful. And probably if more data is coming and which confirms one way or the other, will help us bring down the big population which is using tobacco in a wrongful way to a safer use modalities. And the last I would like to finish with saying that we need to start with what I call hop, step, and jump approach, in which we take a smaller step in making sure that we realize that people are aware of the safer ways of using tobacco. The next step is then looking into and getting more data on how these safer agents can help you quit in a long term if you want to quit. And again, what could be the beneficial effect of transitioning them from smoking a cigarette to other forms of it, and then maybe putting in futures too. And I'd like to thank you all for bringing me to this forum and having me be part of it. I'm looking forward to the outcomes and probably the future changes we could make in our regions. Thank you, and over to you, back.
Thank you very much, Abbas, for your most informative talk and also your contribution to our report. We will now move to Dr. Kentra from Kazakhstan. We just want to see if he's online. Yes. Shintatas, the floor is yours. Dr. Kentra from Kazakhstan. That's Dr. Anders Milton from Sweden. They're all handsome. Do we have Dr. Kentra? If not, we'll move to Dr. Anders Milton and do Dr. Kentra after that.
Thank you. I will fill in what and explain to some extent why Sweden has been successful in reducing smoking. I think Carl Fagerström mentioned it, but I will try to exemplify further. Now, the reason perhaps why we were more successful than many other countries is that we have an alternative to cigarette smoking. I mean, there are about 70% of the men in Sweden that use snus daily, and about 5.6% that use cigarettes daily. So we are on the same way of using tobacco as the rest of the European Union, more or less. However, we have an incidence of lung cancer which is very much lower than in the rest of the European Union, and we are very successful when it comes to non-smoking. And the Swedish government has done basically the same things as every other government has done in the European Union. We have forbidden smoking in restaurants, we have forbidden smoking in cafes, we have forbidden smoking outside of cafes and restaurants if they have tables to sit. And you see, very seldom you see somebody with a cigarette smoking. And you know, we've been successful. It's not the government as such as done this. You know, it's been in the making for many decades. We have had snus for 100 years at least, and now it's made in such a way that it's non-cancerous. You don't get cancer from snus, to the detriment of many of the activists on the other side. You don't get cancer from snus, you get cancer from smoking cigarettes. And you should avoid that, smoking cigarettes, but you can use alternatives. They are not in any way health products. You know, you should avoid snus when you are pregnant, for example. And there are other instances where the snus can make the problems that you have more serious. But compared to smoking cigarettes, it's a health product, really. And as such, it could be used anywhere and basically any time. And I think that it's unfortunate that snus, for example, is forbidden in the rest of the European Union. And now, as we know, we have so-called white snuff, snus, which only contains nicotine, no tobacco. And it's most likely less dangerous than ordinary snus, which is very, very, very safe, as it were. But you know, the white snuff, the snus without any tobacco in it, is like it's the same it's the same ingredients as what is used in healthcare sector, and it should not be banned. So anyway, stop smoking and use some alternative. That's the message from Sweden.
Thank you, Anders. By the way, my name is Delon Human. I'm one of the co-authors of the report. Jessica is just attending to a small medical emergency, and I'll take over as moderator for the time being. We now have, we had Dr. Anders Milton, who's a co-author of the report, along with Carl Fagerstrom. And now we have Dr. Anup Mishra. Dr. Kentra first.
Thank you. Thank you. Thank you, Delon, for inviting me here in front of this expert group. The harmful effect of tobacco and what are the alternatives. I'm not going to say much about the situation in India, which is almost similar to the situation in other countries on which the report has been written. But I would say that this report is an excellent way of putting the thing forward. It has summarized the problems with the smoking, the effect on the mortality and various diseases, and how in these 4 countries the alternative, the smokeless tobacco, could be not smokeless tobacco. There are alternatives. Could be used to decrease the death, mortality, diseases, and many lives will be lost. I would say that this group picks up more countries apart from these 4 countries, because situation is almost similar across the Middle East, across Africa, and across South Asia, and up to the Southeast Asia. And if this group takes up the case of larger number of countries, more lives will be saved, and we will have our governments listening to this such kind of reports, and more measures to prevent death will be taken. Thank you.
Thank you. That was Dr. Anup Mishra, who is a prominent physician from India and a co-author of this report. We are most grateful for his contribution also today. Next, we have a video from Dr. Kentra from Kazakhstan.
Hello, my name is Gintautas Kentra. I am the Vice President of the non-governmental organization Densolik. Densolik means health in Kazakh language. The aim of our organization is to reduce the harm caused by non-communicable diseases, which are known to be the main causes of the premature death. The main area in which we work
Ben, which of the authors are online, and then we can go straight to them. So just to explain what will happen to the report, is the report is being launched today to especially the 4 countries that have been selected and included in the report. And it's been widely disseminated to policymakers in those countries, as well as to the media, just so that we can raise awareness and make sure that in the lead up to the COP10 conference in November, that policymakers and all important stakeholders have a good understanding of what is really the primary function of WHO, which is to prevent disease and premature death. And this study was conducted by this group of international authors to make sure that that primary function is underpinned by good science and good references. So we are most grateful to the 15 authors of the report, and specifically the 4 countries selected, which are part of what we would call the lower middle income countries. So if you look at the report and specifically the estimated number of lives saved, that's really the message that we want to bring across. We are intending to get some of the other authors that are online to add some comments, and then we'll have a general question and answer. Ben, maybe if you just show who's online. So Professor Solomon Ratemane is a psychiatrist, advisor to the Ministry of Health, and a very prominent global health advocate in the field of psychosocial rehabilitation. Prof. Solly, if we ask your comments, please.
Thank you, Dylan. I hope I'm clear enough.
Yes, you are.
Can you hear me very well?
Yes, thank you.
Thank you. I just want to, first of all, I want to endorse this report. I think it's very clear. It's helpful to educate both leaders in our countries, professionals in various spheres who deal with patients who smoke at different times of their lives. But from what Derek and what Jose said, there are a number of implicit issues that we need to work on. The first one is to step up advocacy. It's very clear from what Jose said that a number of doctors do not have enough knowledge about what nicotine is, what its effect on the brain is, does it cause cancer or not? Secondly, they don't know what the smoke in combustible tobacco contains, the carcinogens that we refer to. There's need to promote more and more webinars, discussion groups, bring about the table experts who can talk about these issues. I think that's very, very important. So advocacy and education are key. The next point, which I think is very important, based on deliberations in tobacco harm reduction meetings in Athens, it's very clear that we need to also work on a systematic program of making people understand harm reduction. I think Jose is tired. He is very tired of explaining this, but I think we shouldn't be tired of explaining and re-explaining principles of harm reduction. Currently, I'm at a global policy conference in Cape Town, and interestingly, there's been comparisons between the Framework Convention on Tobacco Control and the proposed Framework Convention on Alcohol Control. The Philippines, for instance, presented a study showing increasing in taxations. What that study basically told us is that the taxes went higher, the government received more revenue. However, people are continuing to smoke and drink without appropriate information. So more education, giving people enough information to make informed, decisions and make, choices that they like. It's very, very important so that they cannot blame people. But what is also becoming clear is that those people with more knowledge about the dangers of combustible cigarettes and the safety and improvement in health because of the alternatives, such as, who testify about improvement in their health, have either quit smoking or reduced smoking, and are now educating people in the field of smoking, discouraging them from using combustible cigarettes. I think the last point I really want to make is that I know some people become impatient with politicians, but they govern the countries, they make the laws and so on. We need to be doing more research and presenting it to them. In this conference on the alcohol policy development, it's very clear, same as in smoking areas, that politicians make decisions based on very little information. So we should encourage research at educational institutions such as universities, within communities, private practitioners, and others, so that that research can increase our knowledge. We don't want 10 years later to be told there is not enough information about vaping, there's not enough information about snus, there's not enough information about heat not burn, and so on. I think what Sweden has done is very important. That information is there, the research has been done. The issue is really implementation and spreading in Europe. And Jose has made this point also at various meetings. So to summarize my input, we need to step up education. We need to have a strategy of promoting research at our educational institutions. We need to bring together professionals in various forums and make sure that we teach them about smoking generally, what is in combustible cigarettes, the smoke, what is in the vaping, what is in heat not burn, alternatives. I think that form of approach will also help give people information that will be publicized through the media, and of course, reports such as the one that we are endorsing today. Thank you very much.
Thank you very much, Solly, for your comments. I see we have Dr. Kentra. Thank you for joining us online. Do you have any comments you wish to share?
I have a presentation. It's I can say what we are doing and our point of view of this problem. If you switch on the presentation, it will be great.
Okay. Can we show his presentation slides? Okay, brilliant.
And
here we go.
Beginning,
there's the first slide. Can you see?
The first, I would like to thank the organizers of this event for the kind invitation to be part of this great project. And our organization, it's a non-government organization, National Association for Harm Reduction of a Risk Factor for Human Health, Densolik. In Kazakh language, it's mean health. If you will show the slide, I will tell what it will be better. But if it's a problem, I will continue.
I have the clicker here, so when you want to go to the next slide, just say next slide and I'll move along.
Okay, yeah? I see, just a moment. I switch here.
Just let me know you can see the first slide and then we know we're okay.
Okay, next slide, please.
Yeah.
Great. We started our activities and we acquainted with this concept of harm reduction. It's only in 2016. And from that period of time, we did several activities. Our working group was formed, economical research was done. And 2020, we officially registered in Kazakhstan. Next slide, please. And, okay. We first become why we're interested in carrying out this kind of research. The main reason is that we believe that the concept of harm reduction is an effective mechanism of the reduction of non-communicable diseases, and our health depends health depends on 52% on people, only 8 to 10% on medical professionals. In Kazakhstan, its situation is not good. More than 90% of deaths are caused by non-communicable diseases. And the main causes of that diseases are smoking, alcohol, poor diet, physical inactivity, and drug use. Next slide, please. What do all of these causes have in common? It is addiction, mental and physical addiction. And what we are saying to our opponents, the concept of harm reduction is an internationally recognized approach of correcting the behavior factor in a person's life with the aim to reduce the harm for health from bad habits when it is impossible to give them up because of physical and psychological dependence. We are working in several directions to introduce the concept of harm reduction with government organization, the Ministry of Health, local authorities. We are a member of Eurasian Economic Union Working Group on Technical Regulation for Nicotine Products. Next slide.
Okay. Mhm. And we conduct research in the concept of harm reduction also. We're doing it regularly, but next slide, please, also. Because it's fine. We carry out active institutional development of the association. We participate in various international forums on harm reduction, and we speaking when with our government and Minister of Health, we're saying why we are not government organization participate this many events which happened in the world, but you didn't. And it's they couldn't answer to us in that direction. We cooperate also with countries in our region where the concept of harm reduction is just being to be introduced, and we have close cooperation and sharing of experience with our neighbors countries, Kyrgyzstan, Tajikistan, Uzbekistan, because it's very important. It's our neighbors, it's former Soviet Union Republic, and many things are similar in politics and knowledges in our regions. Next slide, please. What we are doing, we organize educational seminars for non-governmental organization, college and university students for the young generation, because we understand that's preventing of bad habits. It should start it as soon as early, as it's maybe from it's better from childhood. Also, we published some literature on harm reduction. We cooperate with mass media, and the problem in our region today is a low awareness of the concept of harm reduction, including tobacco harm reduction. But we also the problem is that the Minister of Health used only World Health Organization documents, which required revision on some issues in the fight against smoking, even though the concept is used quite successfully in other areas, such as reducing harm from opioid addiction, which is supported by WHO, World Health Organization, and why is our Minister of Health also using, and we cooperate them in that direction very successfully, and why we bring together all concepts of harm reduction, even in the drugs and alcohol and tobacco, even food we bring together. That is for us, it's more easily to explain the harm reduction from nicotine for using examples in another directions for government. And that we started our program educational doctors in our region, different 10 regions in Kazakhstan. We signed agreement with our Ministry of Health that we train it in for harm reduction and professionals, medical professionals in all regions in Kazakhstan. In this year we already trained more than 500 doctors and medical staff in Kazakhstan, and that directions we are moving forward to explain people harm reduction in professional area and in young generation as students of university and colleges. And we are looking also started our activities in school. Thank you very much. And also I wish you good health, and den soliktenis maktibolsun. Thank you.
Thank you very much, Dr. Kentra, for your very informative slides and your talk. Let's go straight to Dr. Hiroya Komamaru from Japan, please, because I believe you have some comments you wish to share. There we go. We can see you. You're on mute. There we go.
So I'm quite impressed of this with this activity you've been dealing with. I just started to know about this just listening because Dylan, you know, gives some information, and this activity is quite good and meaningful. And I wish I could use these information to introduce the knowledge of harm, especially tobacco harm reduction, to the physicians of Japan who doesn't understand it at all. Maybe some of you have been heard from me about this issue, which is the biggest one in Japan, I would say. And the data you have been seeing in this paper as well, the new trend of Japan to reducing the smoking rate rapidly these years. It's simply because of the sales of heated tobacco device. It's just a commercial phenomenon. It's not introduced or covered by physicians or government at all. So that is the point I'm not happy about. But this kind of trend or activity should be introduced somehow in a nice way to the physicians and the politicians in Japan as soon as possible. That's what I think. Thank you.
Thank you very much, Dr. Kumamaru. We'll now, in the last 15 minutes, just hear from Dr. Polosa from Italy, and then Dr. Dilon Human, who is here, and then we'll have some Q&A at the end. So, Dr. Polosa, your comments, please. If we can get him on the screen, give us a few seconds.
Yes. Good afternoon to those who are in the UK, and good evening to those who are in Japan. I'm not just going to reiterate what has been said today by many of the experts that have been on this call. I just want to bring my physician side of the story. I mean, I really echo what Solomon Ratamani just said, which is I really think the problem is about this misinfodemic that is, translating very bad information about harm reduction, nicotine in general. And we really need to counteract this with evidence. The problem with evidence is, as you may know, that it has different faces. So you may have good evidence, bad evidence. And I think there's a lot of work that needs to be done in terms of trying to clarify what is evidence and bad evidence. And this is work for us, for the scientists to be there and try to clarify this. But on more general term, it's very well established fact that many smokers cannot or do not wish to quit. And they will persist in smoking. Talking about the report, I think this very report, offers clear guidance for decision makers on how to assess this reality. This documents the reality check for everybody, not just for the countries in LMICs such as Pakistan, Bangladesh, India, South Africa, and Kazakhstan, but also for any countries where the prevalence of smoking is a problem. So for all these countries, the adoption of gluten-free nicotine products present a viable alternative, but it must be recognized that its huge success hinges on the development of a strategy that incorporates scientific evidence. In my opinion, this strategy should seamlessly integrate the evidence into established healthcare approaches to maximize outcomes that, as Derek Yach just said at the beginning, are sadly currently at a standstill. And to make more, talking about making more meaningful impact, I think maximum cooperation is imperative, particularly at the level of healthcare policies. And probably this is the message I would really like to send to not just all of you that are listening to this call, but to any politicians who might stumble into our document. Please have a careful look at this document, because it's going to open your eyes and may be instrumental and to a different policy approach to your own country. So I really hope that this document is going to make this difference we all hope for. Thank you.
Thank you. Round of applause. Dr. Human, comments, please?
Well, perhaps just to summarize before we do some question and answer, if you can imagine a giant room, and in this room there are 1.27 billion people, and inside the room there's a slow fire burning. And there are some fire escapes, in fact 4 fire escapes, but only 1 is functional. In time, 8 million people per year die because of the fire. And we sit with a situation where if the other fire escapes were to be opened, we can have more lives saved. That's what this report is about. The report highlights the problem, which is combustible cigarettes, 1.27 billion people smoking cigarettes, and of which 1 out of every 2 users will die prematurely because of the smoking. And WHO, in their figures, state that 8 million deaths a year occur because of tobacco-related disease. That's a fact. So what is the solution? The solution propagated by all of us, WHO and all member states, is quitting and making sure that the environment is made conducive for smokers to help them quit. But as physicians, and most of the authors of this report are either physicians or health professionals, we know that it's extremely difficult. You cannot prescribe to a smoker that they should just quit. Less than 4% are successful in doing that. Even if we get more intensive and innovative cessation efforts, you still end up with a very low cessation rate. So what are the other fire escapes? In this report, we've outlined that non-combustible nicotine alternatives, such as oral nicotine pouches, heated tobacco products, electronic cigarettes, offer a chance for smokers who cannot or will not quit. It gives them a chance to switch and then not die. And I think Dr. Letlapi made that point passionately, and that we should start listening to adult smokers and recognize their dignity and their will to live and give them the right information. So in this report, Dr. Derek Yach, as our principal author and one of the architects of the Framework Convention on Tobacco Control, has outlined that if we were to open the other fire escapes, improve cessation, make sure that tobacco harm reduction policies and products make it possible for smokers to switch, and then lastly, if we can diagnose early lung cancers and treat it early, we can save lives. And you all remember that during COVID, this was a big deal. We were all looking at the R number. We all were we were even competing between nations to see how many lives could be saved in COVID. Yet with tobacco control, this is the complete opposite. It's completely ignored. So what are the obstructions? More often than not, there are some anti-tobacco harm reduction voices which are very well funded and who make the case that all of these alternatives should be blocked. Effectively keep the fire escapes closed. And it's usually under the banner that we should protect the children, which we all agree with. But Dr. Letlapi and Dr. Yach made the point that adult smokers have been the focus point in this report and that their lives matter. Martin, as a consumer leader, has made that point passionately. And in this lead up to COP10, I'm hoping that this report will help, firstly, highlight the science behind these estimates, show all the references, and make sure that not only is there awareness raised, but that anybody who would want to disagree with these estimates, that they should do it themselves. That's what science is. Replicate it, duplicate it. Let's have a conversation. And let's make sure that ultimately the first and primary function of the World Health Organization and of all stakeholders in healthcare is to prevent disease and premature death, that we uphold that principle. So I'm delighted that we can use this report as part of many other reports on lives potentially saved through modeling, that we could use that in the next few weeks and months up to COP10 and beyond to make quite sure that the lives of adult smokers living today, the 1.27 billion people living in that room, that they have accurate information, that they understand the difference between combustible and non-combustible nicotine products, and that they are given access to affordable alternatives so that their lives could be saved. So with that, I'd like to thank all of the co-authors, and in particular, Dr. Derek Yach, who's had a passionate commitment to global health all his life. And I would suggest that in the question and answer, there are a few questions that we give Derek a chance to summarize and perhaps highlight the main points of the report again.
Absolutely.
Thank you.
Are there any comments or questions from in the room, first of all? Yes.
Thank you very much. My name is Maxwell Marlowe. I'm Director of Research at the Adam Smith Institute, and I am a Fellow of the Consumer Choice Centre. My first question is, can I use this report and the data in this report for my research? Yes. That's very good, fantastic. I was interested to hear your take on a new policy announced by Rishi Sunak at his conference, which is going to make it illegal for people born on 1st of January, I think, 2009, and later to buy cigarettes legally, which my concern is will create a huge black market. He's also going to ban heated tobacco. He's going to ban, well, all sorts of tobacco products, and there'll be greater regulations for vaping. I was wondering what your take on that would be in terms of, you know, as a model, because I thought the UK was doing very well in terms of tobacco harm reduction, and indeed world leaders alongside Sweden. What's your take now that there's reversion towards prohibition?
We'll keep that question, and is Derek online? Then between us we can answer.
Yeah, well, I think it's a really stupid idea, completely, and stupid, dangerous, with zero merit. As you said, not only will it promote not only is it a prohibitionist thing, and we know what happens to prohibition, but it raises questions about the age of consent and how you're going to start shifting this up into different ages. What will follow, I don't know. I just see zero merit in doing that. It may be a nice political gimmick to throw out there, but unworkable.
We also have a couple of questions online. One of them kind of came when Dr. Milton was speaking about getting cancer from snus, not getting cancer from snus rather. And the question is, why then are activists fighting against it with so much pathos, and what's their rationale? And has anyone had an honest discussion with these activists about it? And in general, what's your opinion?
Anders, you're on mute. If you could just unmute yourself, please. Nope, still can't hear you. Nope. Yeah.
Wanted to.
I think part of the answer would be that there are many epidemiological studies looking into snus and cancer. And general outcome is, as Dr. Milton said, there is no increased risk of cancer. Some show some small increase, and then these studies are being concentrating or then magnified. But apart from that, I also think that, and that is always in science. If you do 20 studies, not all 20 will do the same thing, because random things are operating, and that's why we have statistical significance, etc. But I also think that this is not just a fight to reduce death and disease. It is a fight to reduce nicotine dependence. Nicotine is a dependence-producing drug, and that is many having problems with that. Also, I think there is, for many, the reason why they are in this field is to down the tobacco industry. And of course, tobacco industry has not behaved very well during the history, and there are very few that have the courage to stand up and defend a product that is manufactured and that the tobacco industry is benefiting from. I actually, while I'm sitting here listening to all the very important and intelligent remarks, I think, why have we come to the goal being the end game of 5%? The goal for me should be to reduce death and disease to something, and probably zero. And that is more or less possible to do that. So the end game for me should not be 5% or less cigarette smoking, but much less harm reduction. Much more harm reduction, sorry.
Thank you, Carl. Anders, you ready?
I think I'm unmuted now. Well, I think the reason is, as Carl mentioned, a lot of the critics are mad at the industry because representatives of the industry lied previously, and they lied big. And I think that they are paying the price now, as it were. That's one thing. The second thing is that it's as Carl said, Carl Fagerström, it's a dependency. Even if you use snus, you are dependent upon the nicotine intake, and they don't want dependencies. Now you could ask yourself, how does this add, the dependency when it comes to nicotine, but you accept the dependency when it comes to marijuana, for example. I really don't know how that's going to end up, but I think marijuana is very much more dangerous than tobacco. The third thing I think is that the too few physicians that know that nicotine as such doesn't cause cancer. You smoke for the nicotine, but you die from the tar. And the byproducts of smoking cigarettes gives you the cancer. And that's why we have so few lung cancers in Sweden. So we should try to educate the medical profession. That's very important. And try to educate the as it were, the opposition to public health.
Thank you, Anders. Any summarizing remarks, or should we go another online question?
Just one question just came in on the YouTube, so it's from Kurt again, who is wondering if kids and grandkids of people who smoke are considered as mere collateral. He's saying 1.2 billion people who smoke have children and grandchildren, and surely they should be considered too. Echoing Gosi's point, smokers are people too. I think it's more of a statement than a question. But
thank you very much.
Yep.
Thank you.
And I think the last one is just trying to understand from Derek in terms of COP10 and the next few weeks, what are the expectations and what are the recommendations from this report that will be valid and useful in COP10?
Derek, did you want to answer that one and then summarize?
Yeah. I think in the room we have a lot of wiser people who can answer the question about COP10, what we can expect. Based on the past, we can expect very little of positivity. I think we need to be already starting to think beyond it. I would hope at the very least there's a decision to hold decisions until a review of all the evidence is done by WHO. That'd be a logical thing to do, but logic doesn't seem to play out. Just two summary points. One, and I just want to stress this again, I really think the discussion about children is so misplaced for one very powerful reason, that all of the deaths that we're speaking about between now and 2050, 2060, all of them are in the current smokers of today. These are adult smokers. If we want to bring their death rates down, we have to focus on adult smokers who are smoking today. If not a single child picked up a cigarette ever from today, they would have no impact on the death data until well into the 2050s. Just remember that sobering reality. And over the next 30 years, there are plenty of opportunities to encourage those kids who might pick it up to quit or to do something different. So the displacement of the adult benefits by a focus on kids really needs to be fought back very seriously. I know it's very politically correct to always put everything on the kids, but from a public health, epidemiological, and health point of view, it will make no difference what kids do over the next few years, but it'll be people's lives at stake if we don't focus on adults. And the final point is just a reflection. You know, years ago, I got to meet the two Nobel Prize winners, one Russian, one American, who won the award for their work of Physicians Against Nuclear War. And it raised the point about, again, the centrality of physicians leading the fight. And I just wonder whether we should, maybe we do have an organization called Physicians for Tobacco Harm Reduction, led by physicians, controlled by physicians, and yes, some may regard it as elitist, but given the fact that the biggest problem we face is disinformation and the lack of support of physicians, maybe we need to have a very large organization that focuses explicitly on bringing physicians to the table with one very clear focus to promote tobacco harm reduction. I think that's doable, and I know everybody here who's speaking would be an admirable member to get it going. Thank you.
Yeah.
I just have a few comments, if I'm allowed.
Yes, yeah, a couple of minutes.
Okay, the first one is on the prohibition from the Prime Minister of the UK. Prohibition doesn't work. Whether you're going to do it now or you're going to do it sometime in the future, the outcome would still be the same. So as Derek says, it's a dumb idea. Can you imagine that you have a society where people, the adults in their 20s who were born before a certain period are not allowed to smoke, but everybody else that's older than them can smoke? How do you police such discrimination and idiocy? I mean, it's pathetic. It's copying what came out of New Zealand. The second issue that I think is important is what was mentioned about Japan. What they did was to allow a product onto the market. Consumers had access and they made a choice. And I think that is what is critical, ensuring that alternatives are available in the market. So despite the ignorance of the medical profession and the misinformation that might be there, if product is available, people are not stupid. They can see the difference of a heat-not ban from a combustible tobacco. The no smoke, the things that don't smell, courtesy to other people, improvements of their own health. I mean, when you start using snus and you are not burning anything, you are not encroaching on the air quality. So the key issue is proper information to people who smoke, safe, accessible, affordable products. And we will see the change that we see in Japan without any policymaker lifting a finger or any healthcare professional misinforming the public. The market will do its work. The people who smoke are not dummies. They're dependent on the nicotine, but they know the harm it causes. So if you expose them to less harmful products, they will make the consumer choice.
Yeah.
Thank you very much, Hossi. So what we'll do is we'll end the session here, but I want to say a huge thank you to all of our presenters who are on site and online. It's a real privilege to have you with us, and a big congratulations to all of the authors of the report, to Derek Yach, the lead author, and all of the co-authors. And the Saving Lives report will be available in multiple languages on thr.net and smokefreesweden.org, so watch out for those. And I believe, Dilon, you have one thing you want to say? No? Okay, so thank you very much. And that's it.